You're tuned into Recovery TV, the voice of hope, with your host, John J. Tassoni Jr. Discussions and information on addiction and mental health issues. Now, here's John and today's guest.
Welcome to Recovery TV, and I'm your host, John Tassoni. It's getting worse. It's not getting any better. 1.5 to 2 people per day are dying of overdoses in Rhode Island. Today, my guest, Linda Hurley, is the CEO, Executive Director of Kodak. So welcome, Linda, and thank you for joining us today.
Thanks for having me.
So you came in the studio today, and you told me you're finding some interesting stuff in toxicology reports. What are you seeing?
Well, what's interesting is we're seeing variations from community to community. You know that Kodak has 8 sites in Rhode Island, one of which is at the ACI. And so we're finding a very large predominance of fentanyl only being utilized by the patients that come to us for care in Providence. In Newport, we're seeing a very high surgence, not necessarily a resurgence, because we haven't seen it, I think, since the late 90s, but a surgence of cocaine as well as opiates, and cocaine with or without fentanyl. So cocaine is the substance. And then in South County, we're seeing a big surge in methamphetamine. So I think what we're looking at as a care provider is that we really need to have specialized treatment, because what's important to know is that one medicine or one treatment protocol for, say, opiates does not work for cocaine. Right. And really, what works for cocaine does not work for methamphetamine. Methamphetamine is very, very specialized, and it's because the chemicals that are in the various substances, street substances, if you will, are very different, and they work in the brain differently. So that just like if we have, I don't know, high blood pressure and diabetes and an infection in my knee, I need 3 very different treatments for those pieces. Right. It's exactly the same for the psychotropic effect that these substances have in the brain. So the term is polysubstance use, and you see it in the papers a lot now, that you know, there's not just one person, somebody doesn't just come in and say, I have a real problem. Very few people come in and say, I have a real problem with alcohol. There's always something else. Very few people come in and say, I have a real problem with opioids. Yes, it's a very real problem. You're saying it's heroin, you don't know that you have fentanyl, and you also use alcohol and cannabis or marijuana, you know, to take the edge off times when you have withdrawal from not having the opiates. So, you know, this is a complex disease, and it's getting more complex day by day. Are
you seeing xylazine also?
Yes.
In all the communities that you just indicated, or is it again specialized in different areas? Wherever
fentanyl is highest is where the xylazine is going to show. Okay. And it's difficult to test. We have more, we find out more about xylazine from individuals that are coming to us for care for the first time, and they're saying, you know, I know this is what's, you know, in the product I'm purchasing, because, or, you know, the street drug I'm buying, because, you know, I pass out for 4 hours, you know. But the issue with xylazine, and you've discussed xylazine before here, so everybody knows what that is.
Yeah, the rash, the whole bit.
Yeah. The problem with it is we don't have good tests yet.
So let me ask you this question. You know the fentanyl test strips that we have? So that will give you an indication that fentanyl is in whatever drug you're going to use, but does not give you an indication, or I could be wrong, that xylazine is in that medication.
It does not.
It does not.
And there's only 2 strips on the market right now that are, and they're not as reliable as we need them to be. So
You're talking about the fentanyl test strips?
No,
too?
the xylazine test strips.
Right.
Fentanyl test strips are miracles. They work. Please use them. You know, please have them for family and friends. Just have them. But the xylazine, we don't have a reliable test strip yet. There is one that's being used, but it still has false negatives sometimes, and false negatives can be deadly.
So, just for the viewer's point, you come into your facility, you test for fentanyl, and it shows xylazine. Is the treatment the same for fentanyl and xylazine, or just fentanyl as a standalone substance?
Just like what we just talked about, that's two substances. That's a polysubstance. You just get it at one time. So you have the opiate, which is fentanyl or heroin or whatever, and that works in the brain in one way. And so you may have medicine and other treatment that's going to help you with that. Then you have the horrendously sedative effects. It's a veterinarian's, it's a large animal tranquilizer. So if you have used it enough that you also have a dependence on it, then that's something that you'd have to watch your withdrawal very carefully, because just like benzodiazepines, like Valiums or Xanax or something, that can be a deadly withdrawal. So we really need to pay attention to that. Most of the time so far, individuals that are utilizing heroin or fentanyl by choice aren't wanting to be in a coma, so to speak, for 4 hours after they use. They're missing a big piece. One piece is I'm using because I'm going to not have withdrawal anymore. The other piece is I like the way it feels. Well, if I sleep through the way it feels, then I'm losing half of the upside of my use. So most people don't love that.
Yeah.
It's not like it enhances the product. And it also is very dependent upon the amount of xylazine that is in the substance that somebody is purchasing on the street. It can result in like a comatose state. So people get assaulted, people get robbed, they get raped. It's an awful, awful, awful combination.
Wow. I'm going to take a break. I need a break now listening to you. Not you personally,
I
but
get it.
the information. You're watching Recovery TV, and I'm your host, John Tassoni. We'll be right back with Linda Hurley from Kodak.
Now, back to Recovery TV with your host, John J. Tassoni Jr. Recovery TV is made possible by our supporting sponsors and our title sponsor, AdCare. Now, here's John and today's guest.
Welcome back to Recovery TV. I'm your host, John Tassoni. Linda Hurley, CEO, Executive Director of Kodak, is in the house today. Linda, thank you for joining us today, and thank you for being a sponsor. I wanted to go back to what you had said earlier about the different locations and the different substances that are in these different locations. Is that a plan? Is it planned by drug dealers to do this? If you know, I don't know. I mean, because it sounds like they target different locations for different substances. And that's concerning to me. Because obviously someone like you, someone like AdCare, someone like anybody else, that these locations are doing different substances. And like you said earlier, how do you get ready for someone coming in who you really don't know that they're using? They could be using A over here and B over here and C over there.
Right. And that's what's happening.
Yeah.
Almost always opioids are a part of that cocktail that people have used to provide themselves with relief or pleasure. But my sense is that Rhode Island is small. And if you look at, I'm just going to use the, if you look at the big guys, they're sending it, and then people start cutting it. So it gets what they called stepped on, like cut with other stuff, maybe 4 or 5 times before it gets from the big guys to the people that come to us for care. So it's more local, I believe, than it is international or national. Right. And what we've seen historically is nothing like this. Like, it used to be that just if heroin came in and someone didn't cut it and it was especially pure, then we'd see overdoses. So the people that come to us for care would say, well, I'm still using it and I want the good stuff. So they would go to where that was. And it's always so hard to get it straight in our heads right now if we don't have a substance, and we don't have that disease. But the overdoses back in the day, and I'm talking 80s, 90s, I'm old, so 80s, 90s, turn of this century.
I wouldn't say old, I said you've been around a long time.
People would actually go to that town, like whether it would be New Bedford or Providence or Point Judith, whatever, to get that product. Now, the way that there's almost a haphazardness to how middle stage or street stage buyers and sellers, how they're spreading their product, what they're actually cutting it with, mixing it with. So I don't think, it's my long way of saying, I don't think it's intentional. It's someone says this is a good thing to do, you'll market more if they have a sedative along with the opiate. But I don't think it's a big plan. I think that, fentanyl, we could conjecture all day long. Everybody's talking about China doing it on purpose to undermine the U.S. and it is undermining. Yeah, so
it's working.
Yeah, if that's the case, I don't know. But I don't think it's intentional in Rhode Island from site to site. I think it's what's available to the individuals who are selling the product in their town, whatever's available. I also think, there's a lot of demographic, meaning the makeup of the folks that are purchasing. We know that the fishing industry has always been really, really big on opioids. And and they've also been pretty big on stimulants, because and they work hard and they have to go out and work hard, and then they have to do something about the withdrawal when they go out to work on the ocean, and they come back. So, there's the demographic differences are huge.
Even like, I've been to some seminars with the building trades. The same thing with those folks, you know. Alcohol's a big one, the fentanyl's big, or the opioids are big for injuries, and there's got to be a way that we can get our hands wrapped around this, because it's, as we go, I mean, we're going, this show is going into the 3rd year. Yeah. I always say, I hope someday somebody knocks on the door and says, John, we don't need your show anymore, because we're good. We're all good. But it doesn't seem to be going down that road. It seems to be getting worse. It seems to be getting, people want to experiment more with these street drugs, some because of their recreational activity, and then there's others that have to deal with pain.
Exactly.
And that are not getting the meds that they're supposed to get for whether it's whatever debilitating disease that they may have. And they say, I can't take it anymore. I gotta go to the street. I gotta, the pills, they look the same. I'm sure they're the same. Then the next thing you know, we're at another wake. Right. We're at another funeral.
And somebody's little brother took just one.
Right.
Yeah.
And that's the first time.
Yeah. Which, happened last month.
Right.
So.
But I want to circle back a little bit about your ACI project that you have over there. The numbers are staggering when these guys and ladies come out. how well they're doing.
I know.
Behind the wall. And people don't realize that these folks are being treated behind the wall. They're getting treatment behind the wall. They're getting therapy behind the wall. And when they come out, most, not all, most are becoming productive citizens again.
Yeah. So what's exciting, and we're actually right now, we were waiting on some more information. We work with Brown University. We purchased their services to evaluate the program. And they were waiting, actually needed some more information from, they got it from BHDDH, but they were waiting for more from the Rhode Island Department of Health, probably medical examiner stuff.
Yeah.
And we're looking at seeing the follow-up. One of the problems back in 2015 when we started this program, the medication-assisted treatment in corrections program, meaning all the federally approved medicines for opioid use disorder, including therapy and discharge planning. When we started that, the follow-through when somebody re-entered the community at re-entry was dismal. And now, this is what I believe, we're up to like 89% of the people that receive treatment in the prison, in the jail, are following through in the community. Because the program is with Kodak. And so one of our deliverables is that we take the responsibility of facilitating treatment for the person that was imprisoned, and we take the responsibility for providing facilitation to get people to the provider of their choice in the community of their choice. And if we call or the patient calls and says, you know, Dr. So-and-so, I'm so excited, I'm out, I need an appointment. And doc says, oh, we're so happy. I have one for you 3 Fridays from Monday. Okay, what's going to happen to that individual? So what we do, what Kodak does, is we treat the patient. We provide their medicine, we do everything, and then at that time we make sure that they have transportation to where they want to go. And that is wonderful. That's why we had that remarkable risk reduction, reduction of risk statistic. It was 61 in 18 months, which was 2015 to 2017. 61% of the deaths that population had been seeing stopped. So we're updating that now.
Yeah, we got to take a quick break. We'll be right back. You've been watching Recovery TV, and I'm your host, John Tassoni, here with Linda Hurley, Kodak. We'll be right back after these messages.
And now, back to Recovery TV with your host, John J. Tassoni Jr. Recovery TV is made possible by our supporting sponsors and our title sponsor, AdCare. Now, here's John and today's guest.
Welcome back to Recovery TV, and I'm your host, John Tassoni. Linda Hurley from Kodak is in the house. Linda, thank you for coming in today, and thank you for being a sponsor.
Thanks.
How can recovery help? How can it help? You have 1 minute to tell me that, and then we'll have you back to tell me the rest.
Thank you. What's important is recovery is possible. Number one, recovery needs to, but this is, as we talked about, what makes this diagnosis or this disease so scary is that it's so complex. You know, we talk about what's in it, it's individualized care, every human is different, every brain is different. So recovery is possible. We all say it and we know it, but recovery has got to be guided by a competent, skilled assessment of the individual so that the person that's coming to us for care is absolutely part of their treatment plan, part of what's going to happen. And
we are going to have you come back because this is too long to fit in. You've been watching Recovery TV, and I'm your host, John Tassoni, here with Linda Hurley from Kodak. We'll see you next week.